Hi, welcome to another edition of our podcast on the ASGE guidelines. And today I'm happy to be joined by my esteemed colleague, Dr. Jorge Machicado and Dr. Sunil Sheth, who are both the first co authors of the most recent ASGE guideline on the role of endoscopy on the diagnosis and management of solid pancreatic masses, which is published in GIE. As always, you have seen that our guidelines are based on the best available evidence, in which we have done extensive systematic reviews and meta analyses and followed the GRADE methodology to try to bring you the best available recommendations based on the best available uh, evidence of this time. Thank you guys for being here and for your hard work on this guideline. As I always say, these guidelines take about 1 or 2 years of our lives and are very time consuming, but hopefully are very beneficial for our patients and for our members as well. So, Jorge, we'll start with you. Can you tell us a little bit about the overview of what this guideline is about?
Yes, absolutely. Thank you so much, Bashar. So, in this guideline, we basically explore three different topics. The first one is when we encounter a pancreatic mass, what is the best approach that endosonographers should have for doing EUS tissue acquisition? Specifically, what needle shall we pick, and about the role of a rapid on-site cytology on the evaluation of these masses. The second is in patients who have a pancreatic mass and obstructive jaundice, what should be the best endoscopic approach for drainage of these patients? And finally, we explore patients who have diagnosed pancreatic cancer and who have abdominal pain. What is the role of EOS celiac plexus neurolysis? For this, we conducted systematic reviews and meta-analysis of RCTs for each of the PICO questions, and we have seven different recommendations that we came from for this guideline.
Excellent. So let's jump into these recommendations. So you're an advanced endoscopist. You're going. Somebody comes in into endoscopy suite. They have a pancreas mass, and you're going in. You found the mass. You are trying to decide what type of needle should you use. Can you tell us about the evidence and what we're recommending for this?
Sure. Traditionally, endosonographers have been familiar with the use of fine needle aspiration, which is a simple needle without any specific design at the tip. Over the past decade, there has been a development of different designs in the tip of the needle, what we call fine needle biopsies, that allows to obtain a further tissue and better architecture for biopsies. But there has been debate about what type of needle is superior with regards to obtaining a better accuracy in the diagnosis of pancreatic masses. So we conducted a meta-analysis in which we included several RCTs, and we obtained several responses that allow us to find that a fine needle biopsy is superior to fine needle aspiration in terms of diagnostic accuracy, diagnostic yield, and also histologic yield. So based on this, we offer a strong recommendation from our HSGE guideline that endosonographers should use FNB needles as compared to FNA needles when sampling pancreatic masses.
Excellent. And obviously, to go along with on the same lines, when you're doing F&B, you're putting this in formalin to send it for pathology. When you're doing FNA, you're sending it for cytology. And so we're
Correct.
recommending that you should be putting it, using these needles and putting it in formalin to send it for pathology. Excellent. So what about you decide, okay, you're going to go with an F&B needle. What gauge needle should you use? 19, 22, 25? What did
Uh,
we find about that?
Absolutely. We conducted also a meta-analysis comparing the different gauges of needles. I specifically compare between the 22 and 25 needles. That's where most of the RCTs have been conducted to compare the data. We found most of the outcomes, including accuracy and diagnostic yield, were similar between the 22 and the 25 gauge needles. However, tissue architecture defined based on adequate tissue for evaluating histopathology, which is conducted in a scale from 0 to 5, 5 being satisfactory. The RCTs demonstrated, interestingly, that the 22 gauge needle was superior to the 25 to obtain better tissue architecture. Now, this may have relevance when we are considering sending sample for next generation sequencing or doing additional studies for patients with pancreatic cancer. So, because of that, the HSGE suggests as a conditional recommendation to use 22 over 25 gauge needles for tissue acquisition.
Excellent. So I think that's an important recommendation. And more, we're doing this next generation sequencing on these cancers to try to personalize therapy. So I think that's very important. Okay, so the next question is you decide you're going to use a 22, you decided you want to use an FNB needle. What are the different kinds of FNB needles and how do we choose between them?
So there has been a development of the different needle designs over the past decade. So initially we had different needles that we call alternative needles because they had a design at the tip that was not very helpful to maneuver within the echoendoscope. However, over the past few years, there has been the development of the fork tip and the Francine tip FNB needles, and these have really revolutionized our field in obtaining a sampling of pancreatic mass. So in our guideline, we compare these contemporary FMB needles with those alternative needles. And what we found is that the contemporary needles were better in terms of getting better accuracy, better tissue architecture, better diagnostic yield. And for that, our committee made a strong recommendation in using novel design as compared to the traditional alternative design. Now, this is a moving field, and there's always development of new needles, and it's an exciting area where there's definitely room to improve to increase the accuracy in the diagnosis of pancreatic masses.
Excellent. All right. So one last question while you're doing the FNA. So to summarize, you're doing FNB. You decided we're going to do FNB. We're going to use maybe 22. We're going to use one of the contemporary needles. The question is, what's the role of rapid on-site evaluation or ROSE in these patients in this patient population?
Yes. So the role of Rose was initially introduced when we used fine needle aspiration. And over time, we have learned that with fine needle biopsies, maybe something that is not necessary. So there has been several randomized controlled trials comparing the use of Rose versus no Rose. What we find overall is that Rose increases the procedure duration without an impact on diagnostic outcomes for diagnosing pancreatic masses. Now, when we stratify this into people who have a fine needle biopsy, we actually found that people who are getting this with Rose are actually getting less tissue. It's probably because the needle is spread first into the slide, and this may decrease the tissue architecture at the time of sending it for pathology, and also increasing the procedure duration. So because of that, when we do a fine needle biopsy, it's totally fine to send it straight in formalin without doing rapid on-site cytology. Now, if for any reason we want to use ROSE to guide a treatment decision at the same time, for example, if we're considering doing a US gastrojejunostomy or a US guided biliary drainage, perhaps we want to understand better if it's cancer or not. That may be helpful to guide immediate treatment decisions. But we caution endoscopists to use the results of this to inform patients post-procedure because sometimes the results can change in the final histopathologic reading.
Excellent, excellent. So basically, we're saying in this day and age of F&B with the new needles, we are suggesting against routine use of rose unless it's indicated. Excellent. Thank you so much. We'll move here to Sunil. Sunil, a lot of these patients, when we see them, they have obviously a lot of pain with pancreas cancer, and frequently we're asked to consider doing celiac plexus neurolysis. What did we find out the evidence is in this patient
Yeah,
population?
yeah. Thanks, Bashar. So to answer this question, we did a meta-analysis on 8 randomized controlled trials, including 600 patients, specifically on unresectable pancreatic cancer. There was no data for resectable or borderline resectable cancers. And what we found was that the addition of neurolysis to medical therapy decreased pain intensity at 4 weeks and 6 months by visual analog scale. as well as decrease the rates of constipation. However, other significant outcomes such as survival, quality of life, opioid use in both arms of the study, as well as common side effects like drowsiness and diarrhea were no different. We also reported a systematic review looking specifically at side effects of neurolysis. And one of the things that we noticed in this review of 16 studies is that there is a rare but real danger of causing spinal cord infarction with neurolysis. In addition to transient hypotension, that is not uncommon, exacerbation of pain, worsening a little bit of diarrhea, procedure related complications such as bleeding or sedation complications. And then, given a combination of these potential adverse effects and the low quality evidence, our committee suggested that we consider medical therapy first in all patients for management of pain. And in only those cases where the pain is refractory to medical treatment, or if patients have serious side effects or intolerant to opioids, then carefully consider neurolysis of the celiac plexus.
Excellent, excellent. That's very good summary. I appreciate it, Sunil. All right, so one last question about these patients. So we talked about FNA, FNB, what to do, and celiac neurolysis. And what about doing an ERCP? Frequently, these patients a lot of time present with pancreas head masses, with biliary obstruction requiring drainage. What did we find out is the best method to use as far as the type of stent?
Absolutely. So we need to understand that there has been a development from plastic stents towards metallic stents over the past several years, and there has been several randomized controlled trials specifically comparing these two types of stents. So we conducted a meta-analysis for this, which is supported by prior meta-analysis that have been published as well, and we found that the metal stents have longer patency than the plastic stents in patients who have mass causing biliary obstruction. Now, in addition to this, there's like less risk of occlusion by stones or debris or material, and there was not a difference with regards to adverse events. We need to consider in this that yes, metal stents are more expensive than plastic stents. However, cost effectiveness studies haven't demonstrated that metallic stents are going to be, different to plastic stents in the long run. I think that we overall recommend as a committee, as a conditional recommendations, that metallic stents are better than plastic stents. And a few settings in which we may consider using a plastic stent is if there's like, perhaps a low potential survival of the patient, because plastic stents can last for 2 to 3 months, and in those situations it may be cost effective. In the past, when we use going straight to surgery in patients who had a pancreatic mass, perhaps the role of plastic stent was helpful. But these days, most patients receive neoadjuvant chemotherapy, so they need a longer term of drainage, and that's why putting a metallic stent is more beneficial for these patients to go through this treatment.
Excellent. What about you decide to use a metal stent? When do you use an uncovered metal stent? When do you use a covered metal stent?
So this has been has received a lot of attention in the last few years because metal stents are newer as compared to the uncovered stents, and maybe a little bit more pricey, but they have the ability. What we found in our meta-analysis is that they have less risk of occlusion as compared to the uncovered stent. They have a little bit more of patency. Now, that per se was the advantage of the cover over uncover. Other outcomes were very similar. Safety was very similar. One concern has been about acute cholecystitis with cover stents, but in our meta-analysis of RCTs, we did not find any difference about this. And recent data has shown that the risk of cholecystitis with metallic stents is actually low. It's about 2%. Because of all this, our guidelines give a conditional recommendation about the use of cover as compared to uncovered metal stents for patients with malignant biliary obstruction and a pancreatic mass. Now, we need to caution not to use uncovered stents in patients who do not have a confirmed diagnosis of malignancy because it can get occluded and cause more issues.
All right, thank you so much. I want to thank you both for this excellent summary. We encourage everybody to go ahead and read our guideline. And thank you for tuning in again here from the Standard Practice Committee at the ASGE.